Well, I'm very excited to introduce Dr. Elizabeth Goetz. She is one of our colleagues in newborn medicine. She's a newborn hospitalist here at Meriter and medical director of the newborn nursery. She completed medical school and a master's of public health, focusing on maternal and child health at the University of Minnesota, and then came and joined us here. She has been a hospitalist here for almost 20 years and has a specific interest in care for mothers and babies with substance use disorder, and is here to talk to us and educate us this morning. So thank you so much for joining us.
All right, thank you. And I'm so happy to see some of my favorite OBs right in the front of the room. I'm guessing a lot of you guys are residents and are here in person, so happy to see you. I'll see a lot of your backs, not a lot of your friends as we stand in the back of the room for the babies, but we're always here. So I'm Liz Goetz. Thanks for having me here today. Today I'm here to talk about toxicology testing in newborns and our birthing persons. Right up front, I'm going to apologize because I know I'm going to slip and say mothers and women. Just know that my intentions are to be speaking of birthing persons. It's just that after 20 years, it's hard to teach an old dog new tricks. So we have a lot of active conversation right now happening about toxicology testing in newborns, birthing people. This conversation's happening here at Meriter. This conversation's also happening in the broader world of Unity Point Health. And since I agreed to give this talk, I've also seen things come up in the New York Times about this topic, on Wisconsin Public Radio and National Public Radio. So clearly, when a topic like this starts hitting mainstream media, we need to pay attention and address it. So as Dr. Bizzuto said, I've been here for a really long time. I stayed here after my residency, and I've been doing newborn medicine ever since that time. And I remember when I started, it was a smaller nursery by far. And also we didn't have the same opioid use disorder problem in our community that we have now. So when we had a baby that had opioid use disorder, was at risk for withdrawal, it was a novelty, it was a big deal. And every time we had to recreate the wheel. I remember really, really hard conversations, really contentious relationships that all of a sudden sprang out of these situations. So as opioid use disorder has increased its traction in our community, become more of an issue, we really had to address this, and we really had to adapt in the newborn nursery. And since that time, we've really had to evolve, and it's been an almost constant evolution since that time. As I was putting together this talk, I was thinking about how this has evolved in the nursery, and I would say there's kind of been three major transitions that we've gone through. I think the first one was when we realized that this was becoming a more common issue, and what we had to do to respond was develop policy. We had to make guidelines. One of the things we did at our hospital was we started doing prenatal consults, and we were one of the first hospitals, one of the first programs to start doing that. And it was an absolute game changer just to have that connection with our birthing people before they entered the hospital. During that time, we also did a lot of nursing education. There was a huge push for trauma-informed care, and that was a big shift. So the second major shift I would say that we've had is the adoption of a more functional assessment of babies. So I'm going to talk a little bit about this because I think it's important for the OB group to also know how we take care of babies. But transition away from sort of a more paternalistic approach to newborns with withdrawal, stepping back and making it more of a family-centered functional assessment. And that was sort of the second major evolution. And I am hoping and thinking that we're starting the third major evolution in our care of these babies. And that's a sort of reassessment of the way that we are identifying newborns who are at risk for withdrawal and identifying moms who need more medical services around opioid use disorders. So the objectives today are to describe the current management of neonatal abstinence syndrome, NAS, and neonatal opioid withdrawal syndrome, to talk about how to utilize equitable and evidence-based approaches to identify infants at risk for NAS/NOWs, to compare the benefits and harms of toxicology testing, and overall, all of our aim and all of our primary objective in our care of this population is to create a safe space where all pregnant people and parents feel confident that they will come into our hospital and come into our healthcare system and be treated with respect and dignity. So why are we talking about this now? We started talking about this a long time ago. We've been talking about it ever since. I kind of thought maybe I was actually done talking about it, but not. So you guys do a great job taking care of pregnant, birthing people, and we do a great job taking care of the babies. But we know that substance use disorder affects people of all walks of life, including pregnant people. It's not a new issue, but the context in which we're all practicing medicine, especially when caring for vulnerable populations, does change, is changing, has changed dramatically in the last few years. And our care is influenced by shifting societal norms. We're seeing in our community a lot of more potent, more dangerous opioids that are available, easily available, and being cut into everything that people are using. We have a really hard situation with the mixed pattern of legalization of marijuana in our country. When something is an illicit substance at the federal level and illegal in some but not all states, it makes it very difficult to counsel parents. It also means that federal research dollars don't go towards the study of what marijuana does during pregnancy and on developing fetuses and children. As far as pregnancy goes, we have the evolution of the idea of fetal personhood. This is influenced both by societal, political things that are happening in our country, but also by the fact that our medical care is advancing so quickly that we're able to treat fetuses independent of the mother while the pregnant person stays pregnant. And that does change the way that we are thinking about pregnancy to some degree. And I don't need to talk to this group about the erosion of privacy around reproductive rights and decision-making. That's also having a big impact. As far as the newborn goes, we have some changes in the way we care for NAS/NOWs, as I mentioned, and I'll talk more about. And we just also have an evolving medical knowledge about how substance use disorder affects newborns and children. So if this talk was just about providing the best care for newborns and pregnant people, this would be so easy and it wouldn't even be a talk that we'd have to give. We know that if we identify issues early, before pregnancy, during early pregnancy, and provide the services that our pregnant people need, that we can really have a dramatic impact on the outcomes for both the pregnant people, the families, and the babies. We know we need to identify needs. We need to get people engaged in treatment services. We need to address problems like homelessness and food insecurity. And we need to provide supportive postpartum services going out much longer than we do right now. For the newborn, it is important to say, as a pediatrician up here, that it is important for us to know if fetuses are exposed to substances before they're born. It's important for us to know what they're exposed to, when those exposures occur, and how much they've been exposed to. So this is important for us because it helps us know how to take care of the babies while they're in the hospital. It really helps us know how to counsel women and birthing people of all kinds about breast and chest feeding. It helps us provide follow-up care, and it helps us provide possibly long-term services or be on the lookout if needed. Now, those are things we should be doing for all children, but with vulnerable populations, it can help to know ahead of time. But we're not in a perfect world. So we don't live in a world where we can practice medicine just however we want, because I'm sure we would just do it a little bit differently. What we need to do is talk about how to balance the individual needs of babies, of moms, and of all of our families in a way that is equitable and unbiased and evidence-based. So we have to do that within the current framework that we have right now. We can go out and we can try and make changes in the laws, but that's not going to happen overnight. So let's talk about what we do now with what we have. So let's talk a little bit about the framework that we're taking care of families in right now. So in the early 90s, in response to Ronald Reagan's war on drugs, I think I was watching MTV in my grandparents' basement at this time, increased media coverage of crack babies, widespread drug testing emerged as kind of a common part of obstetric care. Targeting crack babies placed a disproportionate burden of testing on an already marginalized populations. And ironically, cocaine doesn't turn out to be such a dangerous substance to be exposed to if you're a fetus and a newborn. So it was very misguided. However, during this time, there were a lot of laws passed around the country and in Wisconsin that have had a really lasting legacy on how we're caring for our babies right now. So there was federal legislation, and I have a slide on that in a second, but what it led to is an amendment of the child protection laws with Wisconsin Act 292, which is called the Cocaine Mom Law. It has another name that I can never remember the name of. But what this is legislation that's written into our state code in 1999 that added unborn child to Wisconsin child abuse provisions, defined people as being human from the time of fertilization to the time of birth. So this is a big deal. In this structure, substance abuse during pregnancy is considered child abuse, which has a pretty big impact on the pediatric world. Written into this law are grounds for civil commitment. And the language in this law is so shocking to me. And I'll just read what it says. So unborn children have certain basic needs and therefore need to be free from physical harm due to the habitual lack of self-control of their expectant mothers. This is the actual act. I just highlighted an outline because it really makes me mad every time I read it. So the federal law that this amended was the Child Abuse Protection and Treatment Act, CAPTA. During this, I think it was revised in 2000, this part was written in the late 90s, but federal legislation that mandates that states track data on substance exposed newborns and ensure a plan of safe care. And it requires notification to Child Protective Services. So the state level response was Act 292, which we just talked about. And this does allow the state to take physical custody of pregnant persons, to assign a lawyer to the embryo or fetus, but no lawyer for the pregnant person, to force the person into treatment, psychiatric hospitals, or even jail. And hearsay evidence is permitted, meaning there doesn't have to be any confirmation of any of this. It can just happen based on report. So, hold on. Okay, so I looked up to see how often this is used, because there's a lot of laws that are on the books that you're like, okay, well, that's not really ever used. And according to statistics published by Wisconsin Department of Children and Families, each year for the past 5 years, there have been approximately 460 Wisconsin women who are affected by this law, who are put in jail, forced into medical treatment, or put on house arrest due to suspicion they are pregnant and have consumed or may consume alcohol or a controlled substance during their pregnancy. What is the impact of this mandatory reporting? So despite our arguments, and we hear them often, that these laws are put in place to provide protection to women and children, to connect them with services, to make sure that they're getting the care they need, the evidence tells us something different. So apprehension about CPS involvement can actually deter individuals from engaging with resources that might link them to CPS. Moms with a history of custody loss are more likely to receive inadequate prenatal care in their following pregnancies. Among pregnant and parenting individuals who use drugs or have substance use disorder, fear of CPS involvement and custody loss contributes to avoidance of prenatal services. And when reporting leads to CPS involvement and child removal, custody loss has been associated with increased risk of recurrence of use and opioid-related overdose among mothers. What else are the impact of these punitive measures? So if we're trying to connect moms to services and help them, then this study would say that actually the annual rates of NAS go up in states that have punitive policies. So this study compared 3 states that had policies at different points in time. So no policy, policies in place for less than 1 year, and policies in place for greater than 1 year. And you can see that the annual rate of NAS actually increased the longer the punitive policies were in place. So what this does is force a conflict between providers and patients. Out of fear of legal ramifications, women do not seek medical care, may not disclose substance use. This exacerbates the distrust and ultimately means that pregnant people are not getting appropriate services. This happens before birth. This is happening during the birth hospitalization, and this is happening after discharge. All of our major governing bodies, ACOG, SAMHSA, Family Practice, and the AAP all advocate against using screening on a widespread base to identify these women, because we know, or pregnant people, because we know that this leads to worse outcomes. So a few slides about the changing opioid landscape. So this graph on the left just shows sort of an overview of overdose deaths in Wisconsin through 2020. This is not specific to pregnant people, but pregnant people are part of our population, and this would apply to them as well. So the black line represents all overdose deaths in Wisconsin. The blue line represents all opioid overdose deaths in Wisconsin. And the red line, which is the one I'd like you to pay attention to, is all the synthetic opioid deaths, showing this is basically fentanyl and how the overdose is just rocketing up from that. The problem is only getting worse. In 2022, Wisconsin issued a public health advisory due to increase in fentanyl overdose deaths. There was a 97% increase in deaths from 2019 to 2021, with synthetic opioids identified in 91% of the deaths. A recent report from the Wisconsin Maternal Mortality Report finds that nearly half of all pregnancy-related deaths, in 2016 and 2017 were due to overdose. The majority of these occur right around the time of birth and then from 6 to 12 months after delivery. The epidemiology of NAS is also going up. This is old information. This is the most recent information we have, but safe to say that in general, opioid use is being identified during the birth hospitalization is going up. And our rates of NAS last known had hovered around 8, which is consistent with all of the sort of higher use states in the country. And I always have to put a personal aside about my kids when I give a talk like this, but I have a daughter who I sent to college 4 years ago and one I'm sending to college now. And one of the most striking differences to me is that sending my middle daughter to college now at Wisconsin, it was recommended that we send her with Narcan and the knowledge of how to use it. So that just kind of gave me like a, oh my God, pause. Okay, so let's back up a little bit. I know we have a lot of residents and maybe a lot of people who don't work with a lot of substance exposed moms or pregnant people and babies. And I just want to give a little bit of a background of what this is and how we take care of it in our nursery so that we're all on the same page. So review for some, but information for others. So neonatal abstinence syndrome, NAS, refers to sort of a broad umbrella of babies who are exposed to substances of all kinds and experience a withdrawal syndrome. This can happen with lots of different medications, SSRIs, tobacco, opioids. When fetuses have been exposed to opioids, we worry about a kind of NAS that we call NOWS, so neonatal opioid withdrawal syndrome. These terms are used super interchangeably. I use them interchangeably all the time, but as you go through the literature and hear things, just making sure that everyone understands what the difference is. We counsel our moms who are using substances during pregnancy, using opioids, that most of their babies will have some withdrawal. We say about 60 to 90%. The trick is that withdrawal can be severe and it can also be just really mild. So we don't really have a good way to predict. We think that sometimes the amount of substance, the type, the proximity to delivery can have an impact. But actually, the literature and our experience says that you don't really know what to expect. Pregnant people who are on a lot of methadone can have a baby with absolutely no withdrawal. And we've had pregnant people just on a little bit of pain control whose babies are in the NICU for prolonged times. So it's a kind of take it as it comes situation. What are the signs of this in newborns? So this is where it gets tricky for us as pediatricians, because the signs of withdrawal in a newborn are really the same signs of anything going wrong in a baby. And babies can't really tell us what's going on. So it's all a lot of detective work. We see things happen sort of CNS-wise. They get really fussy. They have trouble organizing themselves. They have trouble settling to sleep. They have GI issues like diarrhea and vomiting, and they have a lot of autonomic instability. So we see things like tachypnea, we see things like fever. So not missing the forest through the trees is a really important part of this, because babies who are exposed to opioids are not immune from neonatal sepsis. They're not immune from congenital heart disease. And we need to make sure that we're able to not ascribe symptoms in a baby to something that we know we can support and will get better, and miss something that could be lethal. when do babies get NAS now? So this is also something that really has a big impact on how we take care of babies. So in general, we're not even going to be thinking about withdrawal for the first 24 hours of life. We don't even start assessing babies until they're over 24 hours old. One of the main reasons for that is that we don't want to confuse tobacco, nicotine withdrawal with opioid withdrawal, because we don't need to treat nicotine withdrawal. And we know that in general, after 24 hours is when this is going to start. So withdrawal symptoms can start up to 2 weeks of life. So that can be a little bit tricky. But we know that generally at about 3 to 5 days, we're going to kind of know which direction babies are going to go. So we watch our newborns in the hospital for 3 days for short-acting opioids. We watch our babies in the hospital for 5 days for long-acting opioids. Now, OB has to discharge the mom before that time, and that's absolutely fine. We have baby mom room in with or the pregnant person room in with the baby. We have all of our services set up so that rooming in is part of our treatment. We provide food and support for the pregnant or for the new families that have to stay in the hospital for a long time with the babies. Our toxicology testing options are also not great. So, and this extends to the mothers as well. So when we do a urine drug screen, it's an immunoassay. Most of the newer synthetic opioids are not included in our immunoassays. And that makes it a little tricky. I put the list up of what substances we typically are testing for, and then the false positives that can come with that. So there is a really high rate of false positives with urine screening. And then with baby screening, the urine can be really hard to get. Remember, they can't really pee in a cup. So it often involves putting a lot of tape around their perineum, and that can be irritating to get that clean catch urine. Babies often urinate right when they're being born, and we like to get the first urine for the toxicology test. The gold standard is meconium. That can also be tricky to obtain. Remember that parents are changing diapers and throwing them away. Meconium is that first baby poop. I'm sure everyone knows that, but just to reiterate that. And then what we most commonly use right now is umbilical cord testing. This test, along with meconium, both have unsatisfactory turnaround times. Usually the results are coming back after we've discharged the baby from the hospital. It's an expensive test. The umbilical cord tox screen is over $300 per cord. And we right now don't have a good place to collect cords and store them for any period of time. So there's a lot of problems. I would say also there are some differences in agreement between the urine, the meconium, and the umbilical cord, which can also confuse our picture. So as I mentioned, the newborn testing is time sensitive, and that plays into part of the reason we're having this conversation. So we have, as I said, babies who may not present with any symptoms of withdrawal until 3 to 5 days of life would be the most typical time frame. But we have a situation where the testing that we can do on the newborn has to be collected either at birth or within the first day of life. So the AAP states that infant testing should only be done when it informs clinical management. And this is kind of the problem. This is the conflict, because we want to manage our babies based on their clinical symptoms, but the testing is confusing for that. So in 2018, I mentioned that we had a big game change in how we care for these newborns. So in 2018, the studies started coming out about the Eat, Sleep, Console protocol. So prior to 2018, the standard of care was the Finnegan scoring tool, and some people may remember that. So under that approach, what we would do is every 4 hours, a nurse would come in the room, assign a score to the baby based on the symptoms they were having. So you'd get like a score of 2 for jitteriness at rest, 4 for jitteriness not at rest, but the laundry list of symptoms. Once the baby met certain numerical criteria, so 3 scores of 8 or 2 scores of 12 in a row, they would be transferred to the NICU and started on scheduled morphine, and then slowly weaned off that morphine. This tool was subjective. This tool was cumbersome. This tool medicalized the baby. And this tool involved the nurse going in and saying, we think that your baby looks like this. We're assigning the score. This is what we're going to do. So what the Eat, Sleep, Console model did, it was shift the treatment of the baby back to the mother. It shifted the assessment of the baby back to a partnership between the nurse and the birthing person. Sorry, I confuse those all the time, and I apologize. This emphasizes non-pharmacologic care, so it just enhances the way that we think we should be taking care of all babies. And it focuses on functional assessment. So we don't really care if a baby's jittery. It doesn't really matter to them. What babies need to do is they need to eat. They need to basically, their jobs are to grow and to bond with their parents. So in order to grow, they need to eat and they need to sleep. In order to bond with their parents and caregivers, they need to sleep so that they can organize their mind, and they need to console long enough to settle to create that connection. So the ESC model centers the parent as a treatment for NAS. Assessments, as I said, are made by parents and nurses ongoing instead of just the paternalistic every 4 hour assigning of a score. And the mainstay of treatment is just everyone working together. Our mainstays of treatment for neonatal abstinence syndrome are non-pharmacologic care, as I said. So this is all the things that we do to just take care of babies. We just amp it up a little bit. So holding, rocking, feeding, skin to skin time with mom, making sure that mom has the proper supports in the room. And then if needed, we do have the ability to do PRN doses of morphine in the nursery. So we can do 4 PRN doses in 24 hours or 2 in a row. And if we exceed that, then we need to bring the baby to the NICU for more monitoring. So I just included this little picture. This was a grant that we did a couple of years ago to sort of illustrate the non-pharmacologic care we give. So we put together these baggies that all moms whose baby's at risk for neonatal abstinence syndrome receive this at the time they come to the hospital. And it has all the things that remind them how to do this non-pharmacologic care. So there's little dark sunglasses we don't expect the babies to wear, but just to remind them to keep the baby in a dark environment. We have a little book that we give, soothing reading. We have a sleep sack. Babies like to be swaddled. They have pacifiers, massage oil, and we actually, in our order set, include physical therapy to come teach parents newborn massage. So we're doing all kinds of things just to kind of rein these symptoms in over the first couple of days of life and bridge the baby through. Breastfeeding is one of the more hotly contested topics when we're talking about substance use in pregnancy. We know that breastfeeding is the best way to feed babies. The contact and the bonding of the breastfeeding and the components that make up the breast milk really can't be replicated. However, there is concern that some substances can transfer into breast milk, and there's always a question of whether these substances place babies at risk. So the AAP and the Academy of Breastfeeding Medicine err on the side of safety, and they have guidelines to sort of that are a little bit more conservative than what we do in our nursery right now. Right now at Meriter Nursery, the times when we would recommend not breastfeeding is if mom has an active IV use going on, and that's more to do with the lifestyle issues. And we also recommend if there's known cocaine or methamphetamine use that we avoid breastfeeding. Part of getting ready for this talk is I really was curious, like how much cocaine is actually getting into that breast milk in the beginning. It's case report. There's not a lot of big studies. There was one fatality, and I just have been telling everyone about this lately because it's an example of how things get mired into the way we do things. But the only fatality was when a mom actually rubbed cocaine on her nipple to alleviate nipple pain, and then the baby didn't do so well with that. I always err on the side of encouraging breastfeeding. I think the bonding and the skin to skin and all of the good things that come with it outweigh the risk of small amounts of substances. But just know that that is something that is hotly debated. So we know that babies are also at a little higher risk after discharge. So babies with NAS are 2.5 times more likely to be readmitted within 30 days of birth after hospital discharge. This is mainly due to growth issues and also continued withdrawal symptoms. The odds of child maltreatment are higher in children who have been experiencing some NAS/NOWs. Probably because these do stay fussy babies for the first couple of weeks to months of life, and they can be hard to take care of. And it's part of our Eat, Sleep, Console protocol is really working with parents to teach them the skills to do this before we send them out. And we know that the risk of SIDS is 4 to 10 times higher in infants with NAS/NOWs. So we do careful counseling about safe sleep. Long-term outcomes, what do we know? We don't know a whole lot. We know there's an increased risk for disorders of emotional regulation, things like conduct disorder, ADHD, adjustment disorders, about 2.5 times the risk. Children with the diagnosis of NAS are about 1.5 times as likely to be diagnosed with developmental delays, anxiety, emotional disturbance, and autism disorders. There are small studies that suggest early delays in neurodevelopment, but these studies also suggest that these findings often normalize by about a year. And then there's mixed evidence on motor development, cognitive development, and school performance all over the map. And part of the issue is that it gets really hard to study this because it is hard to separate the substance exposure alone from the environment, from the milieu, and from all of the other things that influence child growth and development. One thing that illustrates this, there is a study that showed increased behavioral, inattentive, and hyperactive problems in children between the ages of 5 to 12 years old who were exposed to heroin in utero. But when placed in an adoptive environment, all of these things normalized. So I think that just illustrates that it's really hard to know what's going on to separate out any of these issues. So we don't know what coexisting variables matter most. We don't know how epigenetics and genetics are playing a role. We don't know what the specific opioids are having, what they're doing. We don't know what the impact of polysubstance exposure is. How do different treatments impact long-term development? Are we looking at the right things? And what are the mitigating factors? So the Meritor ESC algorithm is available to everyone. It just kind of walks through what we do. I just think everyone should see it. We just ask, is the baby able to eat the appropriate amount? Are they able to sleep for greater than an hour? Are they able to console in 10 minutes? And if all of that's true, we just keep taking care of the baby. We reassess every couple hours. If the answer is no, we have a huddle to amp up the non-pharmacologic care. If that's not working, we have a repeat huddle, and that involves a physician, and then we start talking about some morphine, and then we can go down the road to the NICU. So let's talk about what's happened at Meritor Hospital since this time. So we have had, this just shows 2016 to 2022. So the blue line is all of the babies, and this is imperfect data. This is just, but it's pretty good because I collected it all, and I just know that I missed some here and there. But the blue is all the babies that were observed for NAS/NOWs. And then you can see the orange are babies that just stayed in the newborn nursery, never went to the NICU. And the gray lines are babies that were admitted to the NICU. So in general, over time, you can see that we've cut down on the number of babies we've been admitting to the NICU. The numbers have gone down in general, and I'm not sure how to account for that. If we look at percentages, you can see this is just the same data looking a little bit different, but we've increased the percentage of babies who stay in newborn nursery and significantly decreased the number of babies who go to the NICU. Now, this makes a difference because when babies are in the newborn nursery, they're with their families, they're being cared for by normal newborn. Their length of stay on average is 4 days. And once a baby goes to the NICU, the average length of stay is 15 days, and it's just a much more medicalized environment. Our overall length of stay has dropped since starting the ESC protocol. We're down to an overall average length of stay of 6 days, down from 13. And this, I think, is very interesting. So this is the number of days that a baby has gotten morphine. And we've gone down in 2016, a baby received morphine 633 days. So that's, multiple doses of morphine within a day or what have you, or 1. It's just a day that baby got morphine. But in 2022, and I confirm this data, we are down to 36. So we are almost never using morphine anymore for these babies. And anyone who's of my vintage who took care of these babies earlier on 2016, 2017, it was starting to go down. But these were babies who go up to the NICU and they'd be there for 3 months at a time, getting so much morphine. So we've really done a great job with this. Okay, so I know one of the questions is, how do we counsel our moms who are coming in? What happens to them legally and child protective wise? So for our babies in our nursery between 2019 and 2022, we had almost every baby who was observed for NAS/NOWS got a social work consult that's written into our order set. But what happened to those babies? Only 25% resulted in a report being made to CPS. And in 75% of the babies, they just received counseling and connection with resources. So toxicology testing, where do we go from here? Okay, so this is our current policy. This is what we're all looking at right now. So almost 20 years ago, when we started developing these policies, we wanted to really make an attempt to avoid bias. And at the time, what that looked like for us was a lot of women were being tested because they looked like addicts. And so what does that mean? It means nothing. So our impulse was to say, let's create a standardized list of things that we want to screen, in standardized list of characteristics where we will do a screen to take that sort of subjective approach out of it. This is risk-based screening is really what's used most commonly right now. And there are no standard established evidence-based criteria that we know of that would lead us to test. So commonly used risk-based criteria for screening usually include no prenatal care, unexplained prematurity, placental abruption, tobacco use, history of substance use disorder in recovery, history of medication treatment, buprenorphine or methadone, or suspected intoxication on admission. So our list is a little bit shorter. So right now our policy reads known history of drug use abuse during the current pregnancy, known past medical history of drug use abuse, use of prescription, non-prescription drugs for pain control, and late or inadequate or no prenatal care. So problematic still. Screening based on risk factors can lead to missed cases, stereotyping, and stigma. That's what ACOG says, but we also know that that's true. So a study in 2010 in pediatrics found that Black mothers were more likely than those born to white mothers to have screening performed, whether they met screening criteria or not. And this persisted even when it was controlled for criteria for the standard screening criterion, income, insurance status, and maternal education. Another study in 2023, so more recently, found that Black newborns had 172% higher odds of newborn drug testing compared with white newborns, and 31% higher odds of a newborn drug test order than white newborns when there were when there was no drug test, no urine drug test on the birthing person during pregnancy. So if we know that risk-based screening is problematic, why not just go to screening everyone? So that's also doesn't really work very well. So this study in 2015 looked at universal maternal drug testing in a high prevalence region of prescription opioid abuse, that was Ohio, and found that 20% of positive opioid screens were in women with no risk factors. So the universal screening will identify some women that we wouldn't have otherwise known about, or birthing people that we wouldn't have otherwise known about. A similar study recently done in Utah just did blanket screening of everyone and found that there was nearly 1 in 10 births statewide had an illicit substance of some type. Now it was blinded, they didn't control for people who were in treatment or had prescribed medications. The most commonly found things in Utah were opioids and THC. But there are problems with this type of screening. So a drug test at the time of birth is a point in time. Okay, it doesn't tell you anything about history of use, frequency. And then there's also leads to up to bias in reporting. So bias in reporting is known to, so once we do the testing, we also know there's bias that leaks into the reporting. So we know that Black women are more likely than white women to be reported when those toxicology tests come back positive. And we know that Native American mothers are also more likely to be reported to CPS than white mothers. Testing and reporting does not benefit families. So I hate to pick on Iowa, kind of, but this is a study from Iowa from 2017, just looking at what their prevalence of what happened was when they did test and report. So 90% of their hospitals responded, 90% used risk-based testing. And among these hospitals, 87% reported all newborn positive tests, including illicit and prescription drugs, to CPS. Only 35% of hospitals notified mothers that they were making this report, and only 46% offered substance abuse services or treatments to the mothers. Birthing people, sorry. So what does ACOG say? ACOG recommends universal screening with a validated screening tool at the time of the first prenatal visit. Screening based on risk factors can lead to missed cases, stereotyping, and stigma. Any urine or cord segment testing should only be performed when the patient's verbal consent, and a positive test not be a deterrent to care, a disqualifier for coverage under publicly funded programs, or the sole factor in determining family separation. One of the most commonly used verbal screening tools is the 4 Ps. So if we're going to, so the idea is that this is done early in pregnancy in the clinic with the mom and the provider. And then ideally throughout the pregnancy as well. And ideally, honestly, when they come to give birth. But the questions are, did your parents ever have a problem? Did your partner have a problem in the past? Have you drunk beer, wine, or liquor? And then in the month before pregnancy, how much nicotine and probably THC should be added to that? And in the month before pregnancy, how much alcohol did you drink? A positive screen is an affirmative to the last 2 questions. And what it should do is just trigger an assessment. So is this being reliably done and documented prenatally? We've talked a little bit about the utility of having some of this information in the pediatric world. And so the questions are, what happens when this is positive? Is this being done? And how do we communicate this in our electronic medical record? This is a really great study that's also really recent. So this study looked at how verbal screening compared to testing. So this was a study from 2023 that sought to characterize the utility of obtaining toxicology testing at the time of delivery. So it was a retrospective chart review over 5 years that looked at concordance between what a birthing person reported and results of the maternal and newborn toxicology testing. When removing THC, only 3.9% of the parent babies had an unexpected toxicology test. The clinical rationale that triggered the testing in this group of the unexpecteds that were most often associated with an unexpected positive screen were history of recent substance use disorder in the last 2 years, inadequate prenatal care, and maternal medications for opioid use disorder within the last 2 years. So I highlighted in yellow here, and then I highlighted the cannabis use too. So, so those numbers are fairly small. What was the impact on care? So clinical management after the unexpected positive test led to a counseling or referral for treatment in 49% of the birthing people not already in treatment, and a CPS report was made in 81% of the cases with a case not already open. We see that moms had bad outcomes also in the year after the unexpected positive test with overdose, postpartum readmission, mental health issues. So the authors concluded that this infrequently leads to unexpected tox screen. There's higher rates of CPS reporting compared to treatment referral, and poor maternal outcomes in the year after delivery. What about consent? This is something we also are frequently talking about. I think it's pretty straightforward that women need to have consent before they have toxicology testing. This just goes without saying. There was actually a Supreme Court case that ruled that hospital workers cannot test pregnant women for use of illegal drugs without their informed consent or a valid warrant if the purpose is to alert the police to a potential crime, which isn't too far off from reporting to CPS substance exposure in the newborn. ACOG, AAP, everyone recommends that testing only be done with maternal consent. What is the AAP? So it gets a little trickier when we start talking about testing baby materials. So urine, meconium, or umbilical cord. So what does the AAP say about toxicology testing? So it is acknowledged that substance use during pregnancy is important to our ability to effectively provide care for substance-exposed newborns. Nowhere does it say that we have to have this biochemically proven, but the knowledge is important. When inadequate information about drug exposure exists, testing an infant's urine, meconium, or umbilical cord tissue can be important to ensuring optimal care of the newborn. The AAP stands behind the ACOG policy that this should be done by verbal questionnaire early in pregnancy, not toxicology testing at the time of delivery, that informed consent is necessary. And the AAP supports an approach towards substance use that focuses on public health, primary prevention, improving access to treatment, and promoting provider-patient relationship rather than punitive measures through the criminal justice system. Do we need consent for newborn testing? It's not legally required. This is directly from the umbilical cord drug testing labs. I think it's really bad practice to do tests on parents, on babies, families. These are all one unit families without discussing it. I think that we have a responsibility to have hard discussions with our patients. And excuse me, one sec. I think that these toxicology tests can often be used as a backdoor way for us to get out of having these hard, sensitive conversations with our families. So we recently gave a newborn grand rounds, which we're giving another one soon, which you guys should all come to because they're all for the families that we're taking care of. But we did our first one on this topic, toxicology testing, and we did a survey at the end of the talk. We had a panel discussion with CPS and NICU and OB, and we had a community member. We presented some of these topics. At the end of the evaluation, we asked, what is the current practice when it comes to toxicology testing in newborns whose birth parents have a history of substance abuse? So right now, you can see the green is, and sorry, I don't have the percentage, but newborns who meet certain criteria. So that's what we're doing now. That represents our policy statement. Only 2 people thought we should do it on everyone. 11 people, no one. After the conference, did it change the way that people were thinking? And the answer was yes, for the most part. But also interesting is, if you wanted to do screening based on risk criteria, what were the most common risk criteria that people chose? And the only 2 that were really relevant were no prenatal care and birthing person with a history of opioid use not in recovery. So getting to the point where I'm wrapping up, and the hardest thing about putting this talk together for me isn't all the things we've talked about so far, it's this slide. What are we going to do now? So when is testing appropriate? I think some of our NICU colleagues, some of my colleagues are nervous about the idea of not doing any testing. There are times when we actually sort of need to know what we need to treat in the baby. So I don't think anything is ever all or nothing. I think it is the exception rather than the rule. And there are many, many things that we do based on screen, assess. Once the assessment is made verbally, deciding what to do in partnership with the mom. I think that's probably the way that we need to go. So inadequate information about drug exposure, we can get this by talking to our patients. Mother request testing, this is brought up frequently in meetings I've been to recently where they're justifying universal screening. mothers do sometimes request testing. And I think in that case, why not test them? It's a personal choice, but women will be wanting to, or birthing people will want to, demonstrate I'm in recovery, I'm doing really well. I want to breastfeed without anyone raising an eyebrow about it. Having testing when the knowledge of exposure will significantly change the way the baby is managed. So I think that this will probably come from the NICU rather than the newborn nursery, but sometimes this may come up. And are we really ready to move away from testing newborns? I think the answer is yes, but it's going to be a complicated course. So we need to change the way that we communicate this information in the medical record so that we know that these conversations have taken place. We need to have better communication with our obstetric colleagues so that we are having this conversation. We can have a huddle. Huddles are the answer to everything. And we need, as medical personnel, to take responsibility to have these hard conversations and to build trust and to lay the groundwork for not only the care of the newborn in the hospital, in the NICU afterwards, but also these are the children and the families that we're going to be wanting to vaccinate. These are the children and families who are going to come to us with hard medical and social situations throughout their entire life. And so this is important, and it's important that we do it right. And it's important that we do it in an equitable, unbiased, connected way so that we build these relationships from the ground up. And that's all I have, but I do want to put a plug in for my team, because if you guys don't know us, this is who we are. We're around all the time. We're in-house 7 to 5 every day. We do prenatal consults. We'll come talk to your patients. We'll come talk to moms while they're in labor. You'll see us in the back of the room. We go to all of the non-NICU deliveries that need pediatric attendance. And we're really always happy to connect with all of you. Are there any questions or any comments? I kind of went right up to the end because I was a little bit late.
You got a lot of thanks online for a really great presentation. So,
Oh,
well done.
thank you guys.